Good afternoon. So today I'm going to take you through breast anatomy. So if you remember when we are doing anatomy in the first year, one is always plagued with this idea as to what is it that this is going to achieve? How am I going to apply this when I actually go on to decide to become a surgeon? And then you're completely lost because you don't understand. It is not linked together at that time, and you kind of are at sea as to understand what is the application of the anatomy that you're learning when you're in first year. So when you decide to become a surgeon, that is when you realize how important anatomy is. It is like trying to figure out your routes as you drive on the road. It is quite similar to that, and once you know the anatomy, then navigating that space becomes so much easier. So I'm going to take you through those bits which are going to be applicable to whatever you would do in a breast, and not go into the nitty gritty of anatomy, but just try to emphasize on the applied aspect of anatomy. So this is by and large going to be my focus area. This is the area that I'm going to focus on. And let us start with where the breast is located. So breast is located within the superficial fascia, okay? And it comprises of about 15 to 20 lobes. So these are the lobes that are there, okay? And if you look at what is the extent of the breast, because the extent of the breast is important, because if you're going to remove the breast, you know how far you have to go to get the entire breast out. So if you look at the superior margin corresponds to the clavicle, and that is essentially the second rib, okay? And then the inferior margin is the inframammary fold and corresponds to the sixth or seventh rib. Then you have the medial margin, which is the lateral border of the sternum. And the lateral margin is the lateral extent of the breast, and this corresponds to the anterior axillary line or the mid-axillary line. So that is what it is. So let's go to the deep relations. So now you know that's the pectoral fascia. The pectoral fascia is the deep fascia on which the breast lies. So that is where it is. Okay, that's the pectoral fascia for you. So what are the muscles on which the breast lies? So you have the major, pectoralis major. Okay, that's the major. And then you have the pectoralis minor. And then you have the external obliques, which is lower down. I can't show it in this section. Then you have the retromammary space. So the retromammary space is what separates the breast from the fascia. So this is where you have the retromammary space, which is separating the breast from the pectoral fascia. So that is what you have to lift. When you're lifting the breast off the pectoral fascia, or along with the pectoral fascia also, you'll find this retromammary space. Okay, so this is essentially what I told you. So the pectoralis major, the minor. So what are the muscles of consequence to a breast surgeon? So that's the pectoralis major, okay, the pectoralis minor lying under it, and then you have the latissimus dorsi, which is inferior to the axillary vein. Then you have these digitations of serratus anterior laterally, and you have the rectus abdominis coming up here. So this is what these are the muscles that you would be interested in. So then there is this extension of the breast into the axillary tail, which is also known as the axillary tail of Spence, and it extends into the anterior axillary fold. So that's the area. That is essentially the area. So this is where the tail is going in. Okay, so that's the axillary tail if you look at it from the front. So if you want to look at what is happening at the areola and the nipple, what is happening is that the nipple and areola, there is the epidermis, which is highly pigmented, and it is covered by squamous epithelium. So it undergoes a lot of changes during puberty and in the gravid stage. So you must understand, if the patient were to ask you as to why is my areola becoming bigger during pregnancy, that is a norm. The areola enlarges, the pigmentation increases, and then there are smooth muscle fibers arranged radially and circumferentially also. if that is the nipple. Okay. And you also get, it is supplied with a lot of numerous free sensory nerve endings are present in the nipple. That's why it's hugely sensitive. And there are mucinous corpuscles also within the papilla. So what happens to the nipple when the child is suckling? It sets up a reflex chain of neural and neurohumoral events resulting in milk release. So that is how this chain is completed to produce milk. So in an inactive gland, you will find about 15 to 20 irregular lobes of breast, within the breast lobes, and these lobes are separated by septi. So there are septi, sorry. So there are these septi, okay. These fibrous bands can radiate from the mammary papilla, and they are the ones, these septi are what are dividing the breast into lobes. And then there are these fibrous bands which are actually running from the skin or from the dermis and to the pectoral fascia, and these are the Cooper's ligament. So this conical shape of the breast, that tented up look of the breast, is because of the Cooper's ligament, because that is what is keeping it in shape. So each lobe of the mammary gland will end in a lactiferous duct. So we do know that the nipple, about 20 lactiferous ducts open into the nipple. These of course arborize into several generations of ductules going into the breast, but essentially at the nipple there are 20 of them, and each of them broadens just before it opens up into a lactiferous sinus. So in the lactiferous sinus you have two layers of cuboidal cells, and as it goes into the breast it is lined only by a single layer, although this is not of any clinical consequence, but you must know. So during the menstrual cycle, you know that there are going to be changes in the duct, but the duct is still solid. At the moment it's not hollow, but with constant estrogen stimulation, the lumina start appearing and some amount of secretion start accumulating. But in the absence of hormonal stimulation, the gland can regress, go back to its original state, in fact becomes dormant in a way. So during pregnancy and lactation, a lot of activity happening within the breast also. There is a lot of proliferation and development in the glandular tissue. And towards the end of the pregnancy, there is no proliferation. In fact, there is only an increase in the number and size of the alveoli in preparation for lactation. So we know that there is a protein component. There is another lecture on physiology where you can hear more about this, where there is merocrine and apocrine secretion. So now let's come back to what the breast surgeon needs to know. So this entire area of the thorax needs to be well understood, just so that you understand which are the muscles that you need to be aware of, what is the blood supply, the nerve supply, and the lymphatic drainage, because all this is of consequence to a breast surgeon and in the interest of the patient. So you must know the muscles and the skeletal girdles that cover the thoracic wall. To some extent, I would not say you need to pay too much of emphasis on all the bits, but some bits, yes, you must. So we know that the skeletal component is essentially what? 12 thoracic vertebrae, 12 ribs, their costal cartilages, and the sternum. So that entire ring you should be aware of. And the muscular components are fill the spaces between the ribs. So you have the intercostal spaces where you have the external, the internal, the innermost intercostal muscle, and the associated intercostal vessels and nerves. So these vessels are very important. So the intercostal vessels will be very important to you as a breast surgeon. So I will not really harp too much on these muscles, but we must just know that there are 11 pairs which run downwards and forwards, and they are the most superficial layer. And between the costal cartilages, it is replaced by a membrane. Then there is the internal intercostal muscle, which is again 11 pairs, runs downwards and posteriorly. It is opposite to the way the external one was going down. And then you have the innermost intercostal muscles. These are oriented more vertically. Okay. and these fibers are separated from the internal intercostals by the intercostal vessels and nerves. And then you have the subcostal muscle. So subcostal muscle is interesting in the sense that it tends to skip the ribs. So they pass to second or third rib directly below it. So these have the same orientation as the innermost intercostal muscle. And then there is transversus thoracis. This is just to complete the skeletal supply of the skeletal framework of the chest wall. So all of these muscles, they are innervated by the intercostal nerve. So as you can see, so that is how these are supplied. These are the intercostal nerves. And the intercostal vessels are the ones which supply not just the intercostal muscles, but they also supply the breast. So that is what you need to know. So when we talk of nerves, so each nerve gives a large lateral cutaneous branch. So that is what I would be interested in. So what does the lateral intercostal branch, lateral cutaneous branch do? It exits along the mid-axillary line and very close to the attachment of the serratus anterior muscle. And then the lateral cutaneous nerve will give branches that extend anteriorly and also posteriorly. So you can see this is the lateral cutaneous branch. And let me use the yellow. So that's the lateral cutaneous branch. And there is the posterior branch, and that is the anterior branch which is running along the rib. So as the intercostal nerve continues anteriorly, it gives more branches to the intercostal muscles. So the upper 5